Good, very good session. We're going to turn it over to some of the research things we've done. Dr. Anderson, Dr. Matt Halanski is Vice Chair of Research. He's done a great job the last few years, kind of shepherding us in the right direction. So I'm going to have him introduce this, and then we'll give you a little potpourri of the research we're doing. Matt? And Professor now. Just promoted.
Yeah, just promoted. Thank you. Yeah. Hello again. I don't know if you remember, your partners wrote me letters for residency, so I spent some time in Grand Rapids. So good to see you again. First up is going to be Hani. Dr. Haider is going to share some a little bit of two different things. Some work that he's been doing on some mechanical testing of shoulders, I believe. That's very brief. And then he's going to talk much more about some dual mobility hip work he's been doing with industry on. We'll start us off.
Thank you very much. Thanks for inviting me to talk, and I enjoyed the previous talks, and congratulations to all the residents who are graduating this year. I will start with something very small. And my challenge is not to get bogged down in detail so that you get the full picture and not to ruin the timing for all the other talks in this small session. So this is teamwork, and this is the arthroplasty kind of research team and in the lab. So we all contribute to this. In terms of disclosures, I take this very seriously. Our lab is open. We've done over 93 projects in the last 20 years with over 34 companies. So the message from that is that we're not aligned to any company. So there are no marketing links that we have with companies. That's good and bad. We're free, we're objective, they know we are, but also it means that we struggle for every dollar we get because we are not aligned with any company. And those of you who know what I mean know how difficult that is. So these are the companies on the left for which we've done one or more contracts in the last 20 years out of 90. So some of them we've done 4, 5, 6. We've also got some consultancies, and we also have, I mean, these are basically just mine. It becomes very complex to add all the other teams people. And we have small contributions to NIH grants. I'm going to go a quick excursion, like Dr. Halanski said, into something very simple. We're contributing to a big complex NIH grant on 3D bioprinting, if you like, to repair constructs of rabbits, tendons to shoulders. The idea, the technology here is to use the fact that we can bioprint scaffolds in multi-layers and grade them. Imagine a scaffold that has different characteristics near the bone versus near the tendon. And you could make those different in topology, in shape, in layers, and also add biological things to them by hydrogel printing to different compositions. Imagine the recipe, the juice you add in terms of mesenchymal cells, etc., could be varied depending on where the region is. So bioprinting, 3D printing opens up all that. And this is a collaboration with Dr. Duan Bin, who's a tissue engineering person, and Dr. Strubel, who was with us full-time in shoulder surgery. My contribution, our contribution in the lab, was to test their final construct on rabbits. So I'm going to start from here because otherwise I'll get bogged down in what this biology and chemistry. Bottom line is, does the gear work? You could do things and things and things, and there are hundreds, if not thousands of papers. By the way, a lot of it doesn't work if you read the literature. I mean, that's very simple. That's the conclusion yet. But the interesting thing is how they are testing and how they're evaluating. And if it works, will it work forever in the patient? I mean, these are very interesting questions. But in the perspective of somebody like me in the lab, how to test it, we've got millions of rabbits, like 92 shoulders of rabbits and 2 shoulders from each one. After the treatment, if you like, we have 5 groups, one with just a sham control, that's the rabbit intact without any defect in the interface between the tendon and one with defect only, untreated, like healing. The third one is with the bioprinting without fuel, if you like, biological fuel, just a graded construct. And the third one is with some type of cells, and the other one is with different types of cells. So 5 different things. And we test them mechanically, very simple machine. This is like, these machines are 10 a penny in every biomechanics lab, just simple axial. But we had to really understand and struggle how to hold a harvested tendon correctly by freezing parts of it, by keeping the other parts not frozen, so it behaves like almost like physiologically. And these rabbits are unfortunately dead, of course. So it makes it complicated, but we test those groups and compare them. And I'm just very quickly, as I said, I don't want to get bogged down in detail. On the very left of these graphs, this is the sham control. This is how it is intact without defects, without the injury. The next one is injured and self-healing, if you like. Then the green is the technology with the graded 3D bioprinted hydrogels, graded blah, 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 highest technology. On the two, blue and orange, these are that plus some biological fuel, different types of cells to encourage bone growth, et cetera, again, graded differently from in different regions of the construct. And notice that apparently the mechanical bioprinting, changing the topology mechanically, physiologically, geometrically, if you like, grading it near the bone, the scaffold is differently made, gradually becoming different near the tendon, is giving us a huge improvement. Like look at the green compared to the gray. Now, what's interesting, and that's when it gets very biological, the biological fuels, if you like, different types of cells, different dosages, and so on, they're adding very little. And this story, by the way, is repeated in the literature a lot. And I wonder whether even the green itself is truly better for the life of the patient or the rabbit if they were to live for a long time, because it's okay to prove for the sake of a paper that you have some improvement mechanically. The problem with what you guys do is you try to treat the patient for a long time. It's not a matter of, oh, the results are great, goes into the paper. The patient has to still be okay. The implant has to still work. The repair has to still work for a long time. And this is the challenge for the tissue engineering people. I promised I'm not going to talk. The conclusions are on the screen. You probably know more about the biology than I am. And I'm going to just leave that and go to something I know much more about. Now, dual mobility hips. And we are arthroplastic people. I mean, a lot of my lab staff and I, we have two current studies out of maybe over 60, 70 we've done over the last 20 years. We've tested for all the blue chips and medium-sized companies. Dual mobility hips are a new thing. And it's a funny story. I won't have time to tell you why they came up. They came up in reaction to the metal on metal saga. It's a way of revising bad metal on metal implants without revising every component. Dr. Garvin knows a bit of that history, but it inspired some design input to maybe provide advantages. But here is the idea that you'll have almost like a mobile bearing knee, but in a hip. You'll have two articulating surfaces. You have the tan-looking bearing floating. It can articulate on the inside and on the outside. This is good and bad, and that's the purpose of this slide here. It is good in that with that bearing being able to move, if I reach an extreme of motion, like high flexion, high abduction, and or high internal external rotation, and the combination is deadly, especially in a misaligned installation, which most hips are, because surgeons, not all of them are totally perfect, like Dr. Garvin and our people here. What happens is this bearing can shift out of the way and stop impingement. We call that in engineering edge loading, which can have damage to the rim. And also it could cause subluxation, which you've studied So this is a good thing. It's an adjustable design that allows you to reach the extremes of motion without causing mechanical damage. It's a bad thing theoretically, because those of you who've read about literature about polyethylene wear would know that bigger hips in diameter wear more. And I'm going to link this synthesis in these talks, by the way, even on a seminar like today. It's very difficult linking the information from two talks on completely different subjects. So I believe that the problem about low contact area and high stress in polyethylene was a problem of the past. That was fatigue-driven wear due to high stresses, because most of the polys before the 2000s were sterilized in air, not in an inert gas, and they oxidize very quickly and they fatigue. What's left after that, whether it's highly cross-linked or not, are polys which have been sterilized in an inert gas. They don't oxidize, they don't fatigue. What's left is what we call adhesive wear, normal removal of material due to rubbing. And the polys are so good. In fact, now increasing contact area, this is an award-winning paper in the AOS a few years ago, that we showed for the first time from our lab that actually higher contact area, reducing stress, will increase wear. Reducing stress by increasing contact area will increase wear. So the message is good polys need not to have their stress reduced because they're all very good and the stress is good with good design implants. You increase contact area, will increase wear. So bigger hips wear more. That's not a surprise. So now if we have this technology and now add another articulating surface on the outside, which is big, by the way, compared to the inner surface, we should be increasing wear, and that's a concern. So the questions that we ask on the bottom, would having two increase wear, where does the wear come from also? Does it come from the outer or the inner? So we have done two series of tests. One of them I'm going to report here and then digress and go to the other one very quickly. We've tested a full dual mobility, simulating a patient walking for 5 years, and then compare that to a normal fixed bearing hip. And isolated with some innovative fixturing, and I'll show you them, we simulated the dual mobility which cannot articulate on the inside, just the outside, and one where we could just articulate on the outside and not the inside, and compared all these three groups with a fixed bearing. And these groups are in those colors, and they're going to keep on those colors in the graphs and the results. These are some fixtures which we make in our lab, by the way, which is on this floor, 20 yards from here. You can go and see it for those of you who haven't seen it. And I'll show you a picture of the lab in a minute. So this is an example for the outer articulation fixed. Can you see here, we have made some fixtures, made them in stainless steel and titanium to fit into the bearing without allowing the inner to be a hip that rotates. So we're fixing, we're locking that. This hip can only rotate on the outer, dual mobility rotating on the outer only. Now, this is the opposite. This is one we made the bearing, identical geometry from the inside, and made it of the same material, highly crossing poly, but it can only articulate on the inside. Can you see this ball here is fixed? It cannot rotate on the outside. So it's interesting to see which one would wear more and less. And of course, the dual mobility is normal and the fixed bearing is normal as you know them. This is our lab. This is about a 5,000 square foot laboratory on this floor. If you want to see it from the windows, or you can go and have a look here. And we have a simulator room. And that simulator room has got more equipment for testing implants than any other academic lab in the world, in the middle of Omaha, Nebraska. I can't believe how we did it here. But anyway, so the hip simulator used is this, simulates a patient walking for about 5-10 years. And the walking cycle involves flexion, abduction, adduction, internal, external rotation, and forces similar to the human based on an international standard that we help write. These are the waveforms. I'm not going to bore you with them. These are verification that the waveforms are applying to all the groups equally, flexion, extension, forces, multiple body weights reaching during weight bearing, abduction, internal, external rotation, and flexion. These are what the bearings would look like. The devil is in the detail. We could show pictures, but I'm just going to skip through those very quickly. Interesting, this is the cobalt chrome with the outer articulation only. We have a form of wear, a mode of wear called abrasive wear, no matter how clean the patient is. And even in a simulator where it's even cleaner, you get some tiny particles which will cause scratching, and that adds a lot to the wear. So this is the result. After a year of work and 2-3 people full-time, literally, you get these results. The higher the wear, loss of material, the more the risk of osteolysis. Remember volumetric wear? This is gravimetric wear. The difference between the two is just density, it's a constant. And the density of poly is almost 1.92. So let's make another link to a previous talk. Remember the clinical wear results? You said 6 millimeter cube per year. Was that right? Isn't it interesting, whoever said it, that we're measuring the same thing in the simulator? Look at that. This is so much per million, which is per year. It's amazing, amazing. And people say simulators don't work. So we could, on the bench, simulate in a $100,000 contract in about a year what's happening in the patient. Green is the dual mobility. literally nowhere, very little. Fixed bearing as a standard is that one. Can you see that? Fixed bearing, it's much more wear. And that's a 44 millimeter hip. Now, if you do the outer articulation only, it gets much more wear. It's acting as a rotating bigger hip. And if you do just the inner, you get that. So the dual mobility bearing is lower wear than a fixed bearing and even the smaller inner. It means it's not rotating on the outer. And it means it's also working out as a mobile bearing. So I'm going to now conclude with a 2-slide digression. The same study was repeated with another completely different design of dual mobility, same results. So the answer is those dual mobilities do not offer a risk of higher wear because of the outer bearing. And maybe they're working like a mobile bearing where they're decoupling rotations to reduce cross shear. So they are less risky than people thought. And that's what I conclude my message with you today. Thank you.
Thank you, Hani. I don't know if anybody has any quick questions for Hani. We'll grab next is going to be pulling it up here. So just want to update.
No, yeah, I hope
I
that's
think
it.
so. We'll see.
Yeah, that's it.
Okay, so next speaking to us is Dr. Scherl, one of my partners on pediatrics, and this is a project that Aaron, one of our residents, has worked a lot on, and the peds group has worked on trying to define what is a pediatric trauma patient. So.
Yeah, so like Matt said, our study is called Pediatric Orthopedic Trauma, What Defines Pediatric? And Dr. Stockwell actually did the lion's share of the work on this, and Dr. Hasley as well. So here are our disclosures. So trauma is the leading cause of morbidity and mortality in children. And actually, as of pretty recently, it's gunshot wounds. There is a good amount of literature to support the idea that there are better outcomes in pediatric trauma cases when children are brought to pediatric trauma centers versus adult trauma centers or community hospitals. And this highlights the importance of the idea that, you know, children are not just little adults and have unique physiologic characteristics, but that kind of begs the question, where does childhood stop and adolescence or adulthood begin? And how should we define pediatric orthopedic trauma? Should we define it chronologically based simply on the age of the patient? Or should we think of it a little more physiologically based on whether or not their physes are closed? And this was sort of born of sort of a practical problem in that most children's hospitals will treat patients up to a particular age. Their cutoff is 21 or 18 or whatever it is. But from an orthopedic point of view, you know, a 21-year-old is not really a child, and they don't get the same kinds of surgeries and the same kinds of treatments as a 5 or 6-year-old does. And that's different for other things. If you talk to a pulmonologist, a 21-year-old with cystic fibrosis gets the same treatment as a 5-year-old with cystic fibrosis. So for them, it doesn't really matter. For us, it's a little different. So we wanted to find out how other pediatric orthopedic departments in leading children's hospitals do this, and how they manage skeletally mature patients when they come to them. So we did this in 2 parts. And the first part was a 19-question online survey. It had a variety of multiple choice, yes and no, and open-ended questions. And we sent this to one designated POSNA member within the orthopedic department at each of the 2019 top 50 children's hospitals as per US News and World Report. And we chose one person within each department who we know does trauma. And for this part of the study, we had a very high response rate. We had a 96% response rate. We got 48 out of 50 of these things back. 45 of the respondents said they worked at a level 1 or level 2 trauma center. 40% were located on the same campus as an adult level 1 trauma center. 60% were freestanding like we are. The majority, 78%, defined peds ortho trauma by age. The mean upper age limit was 18, but it ranged from 14 to 26. The other 22% did define pediatric orthopedic trauma physiologically based on whether or not the patient had open phases. And 15% of institutions included non-pediatric orthopedists in the call pool. So they had an adult person with them. When we asked them about specific types of fractures, unsurprisingly, everyone said they took care of skeletally immature long bone fractures. Almost everybody took care of long bone fractures in skeletally mature patients. When we asked about things that were a little more complex, periarticular fractures, again, everyone took care of skeletally immature patients. That's what we do. But the number of people who were taking care of skeletally mature patients dropped down a bit. And then finally, we asked about operative pelvis and acetabular fractures, and there was a big drop there. In the skeletally mature patients, almost nobody was taking care of those. We then asked, if you weren't taking care of these patients, what happened to them? And 25% of them needed to be transferred to another facility. The other 75% either had someone on hand who was an adult traumatologist, or an adult traumatologist would come in as needed. So our conclusions from this part were that nearly 80% of leading peds ortho hospitals in the US define trauma by age and not physiologically. And that about 50%, or greater than 50%, manage complex periarticular and long bone fractures in skeletally mature patients, but almost nobody is taking care of pelvic and acetabular fractures in these patients. So the limitations of this was it was a survey. It was only 50 institutions and one response per institution from an institutional representative. So then we wanted to look at this a little more on an individual basis and see what individual POSNA members treated, what types of fractures and what age ranges. So we devised a slightly different questionnaire. It was 30 questions, multiple choice. It was sent out via REDCap, and it was sent to all 1420 active POSNA members. It was approved by the IRB here. It also went through the POSNA Evidence-Based Medicine Committee, and they were the ones that distributed it via email blast. We collected information about respondent demographics, their practice information. We asked some general questions about the types of fractures they treated, and we had 5 questions in which we included x-rays and asked about the treatment of very specific fractures with these radiographic images, and I'll talk about that in a second. Unfortunately, for this part of the study, we had a really low response rate, only 7%. There were 99 completed surveys out of 1420 people that we sent it to. Our results were that 61% of the respondents had been in practice more than 11 years. Unsurprisingly, 98% had completed a PEDS fellowship. 4% had also completed a trauma fellowship. 7% identified as OTA members as well as POSNA members. And 56% reported a special interest in trauma. And I can tell you that that is not the case across POSNA in general. If you ask the 1420 members how many have a specific interest in trauma, you will not get over 50%. So this was a little bit of selection bias right here. In this cohort, there was even a higher percentage that defined PEDS trauma by age. Greater than half used 21 as the upper age limit. But 91% of these people said they had adult trauma coverage at their hospital. So they have an out if they don't want to do it themselves. And about half treat fewer than 20 operative fractures per year in a skeletally mature patient. And 30% would prefer to limit their practice to skeletally immature patients. There was a trend, though it wasn't significant, of the longer one had been in practice, the less one wanted to take care of skeletally mature patients. So these were the 5 scenarios in which we provided x-rays. We had an operative pelvic fracture in an 8-year-old, an acetabular fracture in a 16-year-old, a T-condylar humerus fracture in a 15-year-old, a tibial plateau fracture in a 16-year-old, and a Lisfranc fracture in a 16-year-old. And we asked them, you know, here are the x-rays. Would you provide all provisional and definitive care in conjunction with somebody else, provisional care only, or would you just not deal with this at all? And the takeaway here is that pelvic and acetabulum really are sort of hard stops for most pediatric orthopedists. over 50% will take care of some of these other things, but no one really is taking care of operative pelvic and acetabular fractures. So what we concluded from this was what I just said, that most pediatric orthopedists do not provide operative management of pelvic and acetabular fractures in either skeletally mature or immature patients. Our limitations here, we had a poor response rate, and I think there was some significant selection bias. There has been a real demonstrated increase in the volume of pediatric orthopedic trauma and the rates of pediatric orthopedic trauma referrals. There is a growing concern that there will be a shortage of fellowship trained peds orthosurgeons in the coming 10 to 20 years. It's possible that defining peds ortho patients physiologically may facilitate improved patient outcomes, lets us see the patients who we're really trained to take care of, and could offload the burden of some of these things that we're really not as comfortable treating. And that's about it. Any questions or comments?
Certainly points to the fact that there's no it's local, and it's based on the skill set and comfort level of whether they're so be able to sort of make an announcement.
Yeah, I know. And it's funny though, we started this partially because, we go to meetings and we talk to people anecdotally, you hear a lot of people sort of saying what we're saying, I don't really do it. I'm not comfortable doing it. I haven't done it in a long time. I would rather take care of everyone, skeletally mature and send these 16, 17, 18-year-olds to my adult partners. And then when you send out the survey, everyone's like, oh yeah, I do that. I sort of felt like, I don't know. I was a little surprised by what.
21 years old.
Yeah.
They take care of 10 to 20 pediatric cases, like
Right.
take them.
Right. And that's what sort of, makes sense when you think about it, but we couldn't get that out of the data, basically.
And then it, of course, and his position wherever people in this, I think that involves another influence, right?
Exactly.
And some of your numbers are decreased by one.
And if you look at the study here, there are numbers here, about 7 to 10 people go from here to children's here, about 7 to 10 people go from children's here. It's not a huge number for them.
We're all tagging on 72nd Street as
And you're correct, Paul. It really is a wash. It ends up being about the same. But
University wants to drop their bar lower,
and it's, and we all are. It really doesn't matter. If you drive fast, 7 minutes.
All right, thank you, Susan. Next up is going to be Matt Tao. He's going to be talking about some updates on some of the sports medicine research going on in the department.
Thanks, Matt. Well, I'll try to keep it quick here. We won't get into the weeds too much. Certainly congratulations to our guys that are graduating, and to Dr. Anderson, appreciate you being here, and to the families. I'm going to go over our updates as far as our team in terms of what we're doing. Really nothing relevant as far as disclosures. This is semi tongue in cheek, but the reality is that Liz Wellsand, who's not here today because she has an NIH grant session this morning, is really the head of everything that we do. She is fantastic. Many of you that are in the department know her. She does a really, really good job. I'm just very grateful that she lets me kind of hang on to her coattails with this. So I put this slide up a few years ago, probably 3 or 4 years ago. The University Foundation came up with this thing called the Big Ideas Grant that we submitted a proposal, Hani did, Sergio did. We did not get ours, but one of the things that was fun in that was that it was very collaborative with other places within the university system. And our idea centered around health and wellness, and that had 3 tenets in terms of physical well-being, mental well-being, nutritional health. And so we still, even though we didn't get funded, I think it has helped influence a lot of what we do. And in orthopedics and in physical therapy, obviously we focus a lot on the physical movement side of things, but definitely the mental side of it is really important. Some people, Austin's here. Austin's done some work on this during his year in the lab in terms of mental readiness for return after ACL and things like that. So the mental side of it's really important. There's certainly been things published on that in a variety of domains within orthopedics, but I do think that's a big part of it. But most of our work centers around the knee and specifically the ACL. I'll just go over these relatively quickly. Just to set the stage, you all know ACLs are common, close to 250,000 of these a year. And in terms of what the issues are, I think frame it in terms of short-term consequences and long-term consequences. We all think about getting back to sports, and that's a really important part of it. Let me see if this will work actually. Yeah, good. So that is a really important part of it. Most of these that happen in, young active people, even if they're not quote unquote high level athletes, we want to get them back as safely and effectively as possible. And so you frequently see in the news an athlete will tweet out and say, I'm going to be back and stronger than ever. But if you look at the data, that's really not true. Only about 3/4 of them even make it back to sports. In terms of getting back to the rate and level of sport that they were at before or better, it's really a coin flip. If you look at the rate of return, as far as the professional leagues here, these numbers are not great, right? We take it as a foregone conclusion. You had an ACL, you'll be back, it'll be fine. But the reality is that's not totally true. And this is what we really want to prevent. Even though he's not with New York anymore, it still pains me to see Odell go through a second injury. These are devastating for young people. You have a second ACL injury, the implications of their ability to get back to activities and their long-term health and longevity of that knee is really poor. And so we have to find ways to get people back safely and effectively and in a timely manner. The other thing long-term is kind of the anti-Kevin Garvin effect, trying to avoid knee replacement in young people when they can, regardless of if polyethylene wear is good. We want to try to prevent that. And so we know that these people get arthritis at a much higher rate. And so at 10 years, ballpark, 50% of people have some arthritis, which is 8 times higher than they normally should. Get 20 years out, 80% of people have some radiographic signs. This is one of my guys that's 53, and he played college football, had an ACL tear, I think maybe 2 ACL tears in college. And so he's 30 years out from that, but he's still only in his early 50s. He really has no interest in arthroplasty. So this is a hard problem. And I think this is our bigger long-term goal is if you can understand why that happens, which we don't really understand well, then you have the ability to affect that upfront. And that really has big long-term ramifications in terms of decreasing the rate of arthritis and their health and longevity as individuals, not just with their knee. So one of the studies that we're doing that's very near close to being done is the return to sport study. We know from an abundance of data that if people have normal strength, normal healthy movement patterns, and full confidence that they return in a safer fashion, the reality is most of the time people don't look for that and they just get cleared because they say, oh, you're 6 months out or you're 8 months out, we're going to let you go back. But if they do that, they're in a much safer place. And we're very fortunate here that we have the capability to do all this testing at a high level. But unfortunately, that's not the case across the country. The vast majority of the people that go through ACL rehab just don't have access to lab-based testing. So the idea behind this is using simple, easily translatable and reliable things and seeing if that can correlate to a safe battery of return to sport testing. So in the upper left here is just showing single leg hop testing, essentially just how far can you hop one leg versus the other. This is strength testing for your quad. And then this is just representing patient reported outcomes. So essentially mental readiness for return. When all of those are over 90%, we call that passing their clinical criteria. Then we test them in the lab. So this is a Biodex machine, so just a fancy strength machine. This is trying to denote in the middle here our biomechanical testing, which is a little bit of a nebulous term, but think of it as essentially how they make 3D animated movies, video games, that kind of thing. So it's a 3D motion capture camera system where we're looking at them on force plates, and it gives us the ability to evaluate them very critically, better than you can with the naked eye, and then try to correlate these two together. So 50 participants prospectively enrolled. We're 1 short, so we're almost done. There's been some published on this. Shelby, one of our med students, published some stuff on this last year, but we're excited to see where this goes and see if it's something that'll be easily translatable across the country and try to get people back safer going forward. This is another one. This is relatively new. We just started this about 9 months ago. This is a squat biomechanics study. I kind of alluded to the fact that we know how people move matters. And we think after an ACL, oh gosh, we're excited for you to get back to soccer or football or whatever it is. But before that, you really have to lock in some of these more simple patterns, just walking, squatting, things like that. And it comes down to a lot of neuromuscular control. So just meaning how the muscles or the kinetic chain keep the knee in a good position in space. Okay, so that matters a lot. And that's the basis of this is if we intervene early and try to teach people how to move well in some of these simple movement patterns, will that reduce their risk of re-injury going forward? So this was in collaboration with UNO, or is in collaboration with UNO. Brian Nars, one of the PhDs there in biomechanics, and developed this really neat computer program that essentially they enroll prospectively again. We start to test them and intervene within a couple weeks of surgery. They're given a squat program that's initially very simple, and then after that can increase in complexity. And you can see here, so this is just one of the participants. This is in our lab just across the street. 1 foot on each force plate. She's looking at the squat program here. And this is the output. So it starts out very simply just in terms of just saying, doing a double leg squat down and up. And then this bar in the middle is showing how far you're weighted one side or the other. And then you can increase the complexity over time as far as the task. And you can also increase the data that you're seeing back. So how much are you in forefoot, rear foot, side to side, et cetera. We'll test them multiple points over the course of their recovery and then put them through a similar return to sport battery as they get close to 9 to 12 months when they'd be getting back to activities. See if they actually test better. And then the goal is obviously, hopefully they have a healthier movement pattern, which should in turn reduce their risk of re-injury. So our target is about 27 patients. We're only 4 or 5 in. We're a little bit hampered by getting the lab redesigned right now, but this should be really interesting. We're excited about this one for sure. This is a little bit different. This is a collaboration with UNL. Eric Mark Vicka is one of the engineers there. And this was the graduate thesis work of Matt McManigal, who just got his master's last month in this. And the idea is developing wearable technology that will give us real-time joint data out in the field so that you could do it on the playing field, you could do it in the gym. You don't have to be in a clinic, you don't have to be in the lab, but try to get some useful data in an athletic or some type of activity environment where it's meaningful to the people that are getting back to it, which ends up actually being surprisingly hard to do. So it gives us some sense of why Fitbit and Whoop and some of these things have millions of dollars invested to make this happen. So I'll go over it real quickly, but Matt spent just an incredible amount of time over the course of a couple of years figuring out how to do this. And it really was truly multidisciplinary. He met with the fashion department down at UNL to learn how to work with fabrics. He's using this Cricut machine, which crafters use for how to cut things. He's working with electrodes. He had to learn computer science. He's coding all this stuff himself. It really was incredible. So these are just walking through from his thesis of basically how he built this thing. You can see here how he had to lay the copper tracings. He has to glue this in. I mean, it really was very neat. And then test it and make sure that it is going to stand up to normal activity wear. You know, we want people to be able to cycle this thousands of times if they're out in the field and not have it break right away. And so this is where he ended up with. So this is the final device. It may end up not being the last iteration, but it turned out very nicely. He just joined our staff full time. We're hopeful that we'll still get funding to actually bring this thing to fruition. But we're really excited about that. Very proud of him for the work that he did. It was a tremendous amount of effort. The last one I'll talk about and then be done is ACL walk. This is probably our biggest one. This is the main crux of our work the last 5 or 6 years. And this is really looking at that long-term goal of understanding why does arthritis occur after ACLs with the hope that we can affect that going forward. We know there's this cyclical interplay between loading, mechanical movement patterns, and cartilage, but it's really not understood well exactly how that happens. So the crux of this study is to look at how people move in terms of their mechanics, the rate of physical activity, because we know that drops after surgery. That's fairly intuitive. But then also linking that to how does it affect the cartilage early? We know that years down the road, they get radiographic signs on X-ray of arthritis, but using something with MRI, you can see here, this T2 mapping. So it's a cartilage sensitive sequence that's a little bit different and more involved than just a regular MRI, where we're looking at the cartilage health early. So it's showing us essentially the trajectory of that knee over time. The goal is to understand why this is happening, but also then hopefully have an intervention going forward that could decrease the rate of arthritis. And again, I think if we accomplish anything in the years ahead, this would have the most long-term implications far and away. So this was a very involved study, both from labor on the part of the lab, but also from the patients. They had to enroll within a month of injury. Then they had to do a bunch of testing right up front. They have to wear this, the exact same activity monitor, very sexy on their hip. So it doesn't even get to go on their wrist. They have to wear it on their hip for an entire week. test them in the lab biomechanically, MRI, blood, serum, blood at synovium. And then we test them at multiple points over the course of their recovery, test them all the way out to 18 months. So enrollment's been done for quite a while. We have a few more collections left to go here, but this data set is close to being done. I'm just going to show you what it spits out for us clinically, which was really helpful for the patients, for me in the office, and for the physical therapist. So this is some of the data we'd get. This is a hypothetical ACL patient named Chris Cornett that you can see Chris's motion here, his effusion over time, what his patient-reported outcome scores are. They're lower than we like, considering he's 2 years out from surgery. So he still has some work to do there mentally. If you look at his strength and then what we call the rate of torque development, think of that as power and explosiveness. It's improved over time. I would highlight one of the things that we look at is their strength to body mass ratio. So basically, how strong are they given their size? We like to see that over 3.1 in terms of reducing the risk of injury. So Chris is only at 1.8, so he still has quite a ways to go in terms of strengthening. But this is not actually Chris. This was one of our real patients, but she didn't do great, as you can tell. But this was not actually Chris. So this just gives you a little bit better sense of the mechanics, what we're looking at. As I mentioned, it's kind of how animated movies and video games are made. So it's a 3D motion capture camera system. We actually just got a new system within the past few months where it's markerless. Before you had to have these radio reflective markers on. Now it's totally markerless, so we can watch how they're moving. We overlay that onto a skeleton, and then they're doing various tasks. So in the upper right, you're seeing them do a single leg squat. In the bottom right, you're seeing them do a double leg drop jump. And then they're doing that onto force plates. So then this is some of the data that it'll spit out, essentially, how are they loading the involved knee, the injured knee versus the uninjured knee. It's produced some good data already. This was an award paper just a few months ago at the National PT meeting. Eric and Mark are presenting next month on our national sports meeting on a topic that really Mark came up with completely on his own here. There have been a couple other papers here, but we're excited about this data set finishing because we have a new sports research fellow coming in. I think we will get some really good data out of this. It truly will be a treasure trove because it was prospectively collected. There's so much stuff we can do. Tyler worked on this, Austin worked on this. There's going to be a bunch of other stuff that'll come out of it. We're also really excited about the potential for this new multi-site collaboration with the Arthritis Foundation. They just came out with this about 2 weeks ago. So they're soliciting probably 3 to 5 sites across the country to look at post-traumatic arthritis prospectively. So it would be a huge multi-center study. So we'll see if we get included in that. Hopefully we will. Just a huge thank you to the funding. Obviously, this work does not come cheaply. And so we're very, very grateful that we've been funded to the degree that we have up to this point. And a huge thanks to the team. I'm sure I forgot some people here, but you can see some of our own folks. I mentioned Mark, Tyler, Austin, but Liz does just an incredible job with this lab. It's been really fun. It's kind of a ragamuffin group of people from all different backgrounds, but it is a really fun group. They've worked hard. They've produced a ton. And so very grateful to be a part of it. Any questions?
Interesting. So recently, AI is going to be used as
Yeah. I think and I don't honestly know the computer side of it enough, but the ability to do it without markers is huge because before you had to have these markers where you put them on specific spots. And actually, I wondered if Cook would be here because Cook has used this for the last 2 or 3 years doing their approach hitting. But now if they can do it without markers, it's huge because it lets you analyze things so much easier than, than doing that. So yeah, it'll be cool. So
Awesome. Thanks, Matt.
Yeah.
Exciting stuff. All right. Next up, hopefully it'll download here and open up is Dr. Maegen Wallace. Another one of my partners talking about multi-center study that we're involved with dealing with osteogenesis imperfecta, and Dr. Esposito in the back as well, and giving a little bit of update on that.
Great, thanks. So thanks for letting me talk about our research, and really this thanks needs to start with Dr. Esposito. He started the multidisciplinary OI clinic here in the early 2000s, and I am just able to kind of take over the reins and enjoy having all this patient data. So I'm just going to start with a little bit about our multidisciplinary OI team. So you can see it's quite a list of people. Obviously, orthopedic surgery and genetics and our metabolic team are kind of the core, but then we also have amazing occupational therapists, physical therapists, pain management, social work, the whole gamut, looking across that. And over the past couple of years, we've been able to add more and more specialists as we start looking at these patients not outside of just their bone issues. So realizing that there's a whole bunch of GI issues that the patients have. So now we have a gastroenterologist who comes to clinic. So we're able to really provide multidisciplinary care. And then all these stars are places where we have patients that come here for their care. So we see patients from between 40 and 44 states every year. And pre-COVID, 7 countries, although last clinic, we just had a patient come from the Dominican again. So we're starting to see that come back after COVID. And then these are just some pictures of some of the amazing patients that and families that put their trust in coming here for their care. So in terms of research funding, we became a site for this Brittle Bone Disorders Consortium in around 2014, 2015. And this is an NIH funded study. You can see we're actually in the second of 5-year cycle. So we're going through years 6 through 10 now. Across all the sites, it's about $1.4 million that are given towards mostly looking at longitudinal data. So the Brittle Bone Disorders Consortium is a part of the Rare Diseases Clinical Research Network. The actual BBDC started in 2014. Currently, there's 14 sites. Most of them are in the US. There's a site in Canada, and then there's also one site in Europe. The main goals of the study are looking at longitudinal trial. So the whole consortium goal is to enroll 1,000 patients. Earlier this week, we had a PI call, and we're currently up to 958 patients enrolled total. And our site has approximately 110 patients that were enrolled in the first 5 years. Now coming out of COVID, everybody was kind of on a hold with enrolling. So in the last few months, we're starting to enroll patients again. And so we've got a few new patients that we've enrolled just in the past few months. Currently, we're in year 7 and actively enrolling subjects. And then through the BBDC, they've been able to then expand and have kind of pilot projects. So I know this is kind of small, but you can see there's actually 8 active studies within this consortium. Some of them are looking at quality of life from the patient perspective. There was a study looking at collagen peptides and urinary biomarkers in patients. There's a big push with actually dental things. So there's a lot of issues with if patients have dentinogenesis imperfecta, they have issues with their teeth. But outside of that, they also have issues with the shape of the face and the jaw. And so they have a lot of problems with malocclusion, which then contribute to dietary issues, which then contribute to lack of vitamin D. And you get into that cycle as well. There's a subsection of the study looking at pregnancy. So it's not just kids that are in this trial, it's adults as well. So they've been able to publish some things on pregnancy. And then looking at some other new drugs as well. And then one big push in this second 5-year cycle is looking at psychosocial needs. So they're actually doing like quite lengthy interviews with patients that are willing to do interviews, just looking at pain and other psychosocial issues, medical trauma, and those kinds of things through the lifespan, which has been really interesting. And then a study that they're just now got approved, and they just actually had their site initiation visit before, was actually looking at Invisalign, so the clear aligners, and seeing if those can actually help change and improve malocclusion in patients with OI. So from the consortium itself, there are actually 38 publications. So it's a pretty active consortium. There's several other manuscripts in progress. I became the PI at our site in 2017. And so personally, just from being a part of the consortium, I have been able to have a publication from that. And then the nice part about being a part of a big consortium like this is that if there's anything that any of us want to look at, it's easy to obtain the data. So it's a simple form that any of the PIs can fill out and obtain all the data on all the subjects, but we also have full access to any of our own data. So that we've collected just through the study as well. Every year with OI, we celebrate awareness. So this was our clinic where we call it Wishbone Day, and yellow is the color that we wear. So this is the patient group of patients and parents that came the day in clinic this year that when we celebrated that. And then we're now a site for an industry sponsored trial. So as an orthopedic surgeon, I never thought I would be involved in a drug trial, but here we are. So when you have a large patient cohort and it's a rare disease and there's some exciting things, sometimes you do things that you didn't think you would do. So this new drug is from Mario Biopharma. It's called setrusumab. It's an anti-sclerostin antibody. They've already done an adult study that's been published, and they had a dose-dependent, they found dose-dependent bone building activity on DEXA and a reduced fracture burden in adults. And so now they're starting the phase 2 or 2B trials for children. So the first wave will be just finding the correct dose for those patients. And then after the dose is determined, then the phase 3 trial will be an extension of the 2B trial. And so our site initiation visit is scheduled in August for this. And hopefully shortly after that, we'll be able to enroll our first patient. It's quite extensive. It's monthly infusions, whereas currently with bisphosphonates, most patients are doing every 10 weeks to 3 to 6 month infusions. So monthly infusions, and they have to come on site each month for that. So it's quite an extensive study. And then because of that strong base of patients that Dr. Esposito has built up over time, this is just a small list of current projects that I have going on, some of which are funded and some aren't. Children's has a Children's Health Research Institute, so I was able to get a grant and get some pretty amazing equipment. I don't know how many of you ever heard of bod pod, but it's a machine that you get into and it gives you a ton of information about body composition, so percent body fat and lean muscle mass. So I think we've currently enrolled between 20 and 25 patients and just looking at body mass, because we've noticed that especially as the children with more severe OI, as they get older, they can't move their bodies as much because they break, but then they tend to gain a lot of weight in kind of pre-puberty and into puberty, which when they have small bones that are very brittle contributes to more issues as well. So just another thing that we're looking at as well. So it's kind of where we are with OI research, lots of exciting things going on. So thanks for allowing me to share.
Well, just kind of thinking back to the days when you started with the ratio, made me wonder, where's the ratio now? Ratio bodies
In industry, doing private research, medical director, seems to change companies with new products.
It's kind of the metabolic bone type guy behind this. Yeah.
Yeah, Bruce Bueller asked this. He said, "You want to do any brittle bone disease?" There's this guy that wants to come from Canada. I said, "What's that mean?" So and suddenly it just happened. So one thing I want to comment on it as an academic institution, it's so nice. What Maegen left out is I kind of randomly collected data, just clinical stuff, and which created a lot of confusion. So with Matt here coordinating things, it's so much better to start out up front, plan in mind, and know which direction you're going. It just makes it much better. And the whole idea of being an academic is to make things behind you be better than you.
Don't be too modest.
You don't know.
That's all for you. Oh, thank you.
So I will bring it home. I know Dr. Garvin gave me strict instructions to stay on time, so I had about 10 minutes, I think, but I'll go through this quick. There were two different projects I could give. I will just give an update on one that's a little bit further along of recent funding. Here are just some of the disclosures, and we'll talk about this grant, which was my first NIH funding, which was cool. And it's just getting started. So I think this is for the spine guys because they've been sitting through everything without any excitement. So I think everybody knows, the historical treatment for kids with curves like this would be something like this. And that's just what we've done. But in peds, what really started a long time ago with Dr. Blount, but has gone on from then and gotten much more popular is this idea of guiding growth or harnessing growth using pretty simple implants. So the idea is if you can slow down the growth on one side of a deformed limb and allow the other side to grow, doing something very small, you can get some pretty amazing corrections. And so people have, over the past probably decade, have said, well, if it works so good in the legs and arms, why can't we do that in the spine? And so people trying to avoid the fusion are looking at these things called vertebral tethers or flexible tethers to try doing the same thing to decrease the growth on one side of the spine and allow increased growth on the other side of the spine. But what has happened is it doesn't seem to work quite as predictably in the spine as it does in the limbs. And so what's been shown in the literature is that it does work in some kids, but in other kids, they go through the whole tethering procedure and then end up with a spine fusion anyways. So there are a whole lot of unknowns with this. And what tends to happen in pediatrics, maybe more so than in other areas, are people just start doing surgeries on kids before we actually really know who best would benefit from that. So our grant was really to try understanding the relationship between tether tension, intravertebral disc pressure, vertebral growth, and the ultimate curve correction. And one of the kind of selling points, or I think kind of the sexy point that got us to get funded was we have a spine deformity model in a large animal, which other people don't. And this was something that I got involved with a long time ago while I was at the University of Wisconsin. It's one of those crazy kind of science stories, discoveries. The animal science department there runs a pig herd. They teach undergrads how to raise pigs. And one of the student groups forgot to add some stuff to the mix, their diet mix. And then all of a sudden they started having pigs with these spine deformities. And so then they repeated it, and sure enough, they could reproduce. When you altered the maternal diet, you could create piglets that had big humps. And so we published on this in 2018. I just wrote the numbers down there. So 2013 is when I heard about all this, and we got some little grant funding, and then we worked on this project, and it was finally published in 2018. And we kind of validated that, yeah, these curves do look like they're actually progressive. And, you know, they do kind of look like Schurman's kyphosis. We tried to characterize different things, and it's reasonable. I think it's a reasonable model for kyphosis. So the idea of our study, and this is one of the things that I've thought about with the vertebral tethering, is it's definitely different than in the limbs. And one of the key fundamental things is the Hutter-Volkmann principle, or law, however you want to say it, that the growth plate grows slower under compression or compressive loads than it does under tension, or grows faster under tension. And so you're able to get guided growth to work by asymmetrically compressing one side of the growth plate, which allows the other side to grow. And so some of the assumptions that I've had in this is thinking that a deformed spine would likely have increased disc pressure compared to a normal straight spine. That as you increase tension across the tether, unlike the knee or the ankle, that this is going to increase your disc pressure, and discs are designed to distribute compressive loads. So the thought is, you know, you're going to have this increase in tether tension. We'll see if I can say this. That's going to increase your disc pressure. That's going to increase your load all the way across the end plate. And one of the things that I've wondered is, does that, when you distribute that load, do you really just inhibit growth evenly across the growth plate and not actually allow you to get differential growth modulation? And it's maybe that why it doesn't work as well. So it's kind of a complex problem to try to sort out. But when you look at kind of some of the data from previous clinical studies, what you see is you get this tremendous amount of curve correction right from the get-go. And then when you actually look at the curve correction due to growth modulation, it's pretty minimal. And this was taken from one of the clinical studies. I kind of adapted that data. So one of my hypotheses is if you try to do this aggressive correction initially, what you do is you over tension your tether, which increases your disc pressure too much and actually decreases the ability and decreases growth rate. So you don't see the growth modulation. Hopefully that's somewhat understandable. Again, just showing you that that's what it may mean, that it might explain why we don't really see growth modulation like we see in the limbs. And so we're just now getting started. This was me having some major issues and having to try to solve this in my kitchen. But the idea of this is the first part of it is we put spine implants in. We tension them at different tensions. While we're doing that, we're measuring the disc pressure and then also taking X-rays to look at the change in Cobb angle. And eventually we'll be looking at growth rates. So this is just we've done some of these non-survival surgeries. So this was the piglet on the operating table. That's just the X-ray. These are with our screws in. We initially were going to do this with pedicle screws, but they were too big, so we just used regular cannulated screws. This is the transducer tip within the disc space, and this is just showing again. This is it for these non-survival ones. This is where you can see the little white areas are the discs. These are the ribs that we cut to kind of get this in, and the pressure transducers inside that disc space. Again, that's what it's showing. And so what we do is we kind of tension these tethers, and you can see, as you would expect, I actually haven't even measured the differences yet. This was just done last month. You can see over time, you see a gradual reduction in the curve. And we're going to redo this. We're just in the apical 4 vertebrae here. We're actually going to skip vertebrae on the next run of this to get over the whole curve. Majority of these curves are about 8 segments in length. And then we measure the disc pressure, and you can see we kind of plowed one of the screws here. And that's one of our things, is figuring out how much tension we can actually put on these. And this is made up. This is totally falsified. Don't like tell the NIH, but basically what has happened in all these is we do see this reduction in Cobb angle, not to 0, but we do see it go down as we increase the tension. But this was really the surprising finding just early on, and it disproved one of my initial premises, is that when we actually look at the disc pressure, the kyphotic pigs actually had a lower resting disc pressure than the normal pigs, which I was not expecting. So that was kind of interesting. And then the other thing was, after a certain amount of tension, I was assuming we're tensioning, we're compressing, we're going to see the disc space, we're going to see the disc pressure go up and up and up. But what instead we see is that at a certain place, you see this drop off in pressure. And I'll see if this will play. And this may be due to this change in the shape of the disc. So if you watch the disc right there, you'll see, hopefully you don't hear me talk, it kind of sucks in, the annulus sucks in when you actually extend it, and it actually bulges out when it gets into its native state. So it's a question of, are we actually decreasing the pressure with these tethers not being fixed angle devices? So it's not like you have 4 screws and a rod fixed that you're compressing. This tension allows them to actually open up in the front, which I was not expecting. So it's kind of interesting. The other thing, this could be a technical issue, and I don't know if you can see right there is the hole from when we put that transducer in. And I don't know if we're changing the geometry of the disc, and it just opens up the annulus and lets air in, and that's why we see the decrease in pressure. Could be either of those, but it's really, really interesting finding. So the other things that we're going to be doing, and this is just showing a labeling of the growth plate of the spine. So the pig spine is a little different than the adult here, or than a human. Here's the disc. They do have an actual bony epiphysis, and this is the growth plate. And so what we do is we give 2 different bone labels at different times. And by knowing the time between when this is alizarin red and oxytetracycline are given, we can measure the distance, and then obviously we know the rate at how fast that that vertebral body has grown. So as we move forward and do this in recovery animals, we're going to be seeing what effect that disc change and tension has on the actual growth. So we're coming up next week. Yeah, I think 10 days. We'll actually be doing some more, some both non-recovery and actual recovery surgeries. And then the second part of this we'll be looking at, and this gets into a whole other kind of area that I've focused on, is we've been able to show, and my old partner in Wisconsin did a fair amount of this, that if you resect the periosteum, you can accelerate growth and get things to grow faster. So we kind of did this idea of accelerating growth plus putting, actually he did it, I just got roped in at the end, of resecting, getting the growth to go faster, but then doing the guided growth, and you see a more rapid correction. And so the second aim of this project is to say, okay, if we do correct these pigs, can we correct them faster by incorporating a periosteal resection of the vertebral body, which nobody's looked at yet. So I will end that on that one.
Thank you.
Cool.